Thank you, chairpersons, and thank you, West Bengal Echo, for this very kind invitation. And this was actually meant for the younger audience, so uh, I go through some basics. So we have this interesting case and case summaries on how we all learn and uh, move ahead. So this is a 36-year-old male. He presents with progressive shortness of breath for nearly 1 year with vague chest discomfort. His risk factors include his being a smoker, he's non-diabetic, and normotensor. And we also have his echo parameters. The LV is dilated. There is borderline LA dimension. And the most important thing is we have an EF, which is 33%, a mild to moderate mitral regurgitation, and a pulmonary artery systolic pressure of 40, with the RA and RP being normal. So this is the short case that we have been given, and let us just dissect it and move ahead and see what we can find. So I think the most important thing in any kind of clinical presentation is to dissect those salient points which is going to help you with both the diagnosis, treatment and the management. So we have a 36-year-old male. He's a young person, male. The predominant symptom for this particular patient is shortness of breath. That seems to be a very important part of his clinical presentation, which is progressive over the last couple of months. And the chest pain, for whatever reason, has not been given importance, and we will possibly play this a little below, and the shortness of breath being the more important symptom. He obviously has a cardiovascular risk factor despite his young age, so that he's a smoker, he's an active smoker. And a very important clinical point is we have an echo and the EF is 33%, or as we say, less than 40. And he comes under the HFrEF category. So we do believe that this is a heart failure patient, and we know that heart failure is an important problem. It is a big epidemic in our country, and because of the risk factors like hypertension, diabetes and smoking, which are drivers, the incidence keeps increasing. Now what is important here is that heart failure in India is a little different from what heart failure is in the Western world. And one of the important things is it comes in very young. We must believe that rheumatic heart disease, although most of us are not seeing too many these days, is an important etiology. And of course, there's a male predominance in this whole story. And the risk factors like diabetes is also driving this younger epidemic. So let us look at the diagnostic approach to this patient, now that we know that he has a reduced ejection fraction. And when you look at the whole story, you will see that the males predominate in the REF region, whereas in HFpEF it is more a female predominance. And the HFpEF incidence is also increasing in our country because of the use of BNP and echocardiography. So a little throwback on the pathophysiology, and you'll know that we did learn about the heart failure as a forward versus backward failure, not very pertinent today, but the essential pathophysiology remains the same, that there is a neurohumoral activation, there is a renin-angiotensin activation with aldosterone excess, and that causes the salt retention. The sympathetic system gets activated, there's vasoconstriction, and this whole milieu leads to both the forward and backward failure. And this is an endless loop which causes progressive deterioration of the left ventricular function. Now, when you look at the symptoms of this patient, dyspnea seems to be the hallmark of his symptom. And the other symptoms that usually go along with it is fatigue, swelling, edema, orthopnea, and PND in the extreme case. What is also something that we have seen and is very particular in India, especially with the women at home, is bendopnea. Is whenever they bend to do housework, they get breathless, but they're otherwise comfortable. So an important eliciting history here is to get that history, especially if you have a sedentary person, and you will find that it is present. So when we look at the findings now, when this patient comes to us, there are respiratory findings which include the crepitations, rales, but also there is a possibility of you getting a wheeze. And this is not something which is an intrabronchial problem, but it's because of the edema compressing. There is an expiratory wheeze which is sometimes mistaken in peripheral setups that this patient has a chronic obstructive pulmonary disease or a bronchial asthma, and the treatment completely goes over. Pleural effusion again is an important thing, and X-ray and lung ultrasound can pick these things up, which may be subtle parts of heart failure.